I'm Dr. Erica Bove, and welcome to the Love and Science podcast. I'm your host, and also the founder of Love and Science, Thriving Through Infertility. I'm so excited you're here today. With over a decade of experience helping thousands of women just like you, I empower professional women to build their families with confidence and compassion. Let's dive in. Hello, my loves, and welcome back to the Love and Science podcast. We have an amazing distinguished guest today. She is a friend. She's a colleague. Her name is Dr. Shivana Naidoo. She is the creator and host of the podcast, Thinking It Through with Dr. Naidoo, child psychiatrist and founder of Do Better, her telehealth private practice. I met her at the Women Physicians Wellness Retreat, the conference in Grand Cayman, where we were both speakers, and we instantly connected. It was just this amazing, amazing flow of ideas and shared ideas. And I'm just so grateful to call her a friend and a colleague. So Dr. Shivana, it's so wonderful to have you. Thank you for coming on the podcast.
Oh, yes. Thank you so much for having me. I felt like once we chatted, we had to connect outside of that space again and continue our friendship and conversation. So glad to be here.
Absolutely. Thank you so much for being here. So you are a psychiatrist, and I think that many people say what we do in REI is like gynecology, right? And I know I would never claim to be a psychiatrist, but I think there is so much intertwined in the issues that we sort of face as gynecologists, what the patients go through with infertility that is deeply, deeply personal and very much in need of mental health. Tell me a little bit about your journey to psychiatry, what drew you to it as a field, how you see parallels with gynecology and the women's issues and the infertility struggles that we see. I'd love to hear a little bit about your story.
Ooh, okay. Well, I went into medicine because I'm a South Asian female. That was going to be what I had to do in part, right? That was what it meant to succeed, right? My parents immigrated from a country called Guyana. For their child to succeed, you got to become a doctor, lawyer, engineer. So that was kind of ingrained within me. And I kind of resisted it for a while because I didn't want to just do what my parents wanted me to do. You know, I applied to a bunch of 8-year, 7-year medical programs when I was in college, and I rejected all of them to go to UPenn, thinking it'd be so easy to get into med school. Wrong. It's hard to get into med school. So I ended up going to St. George's University in Grenada. And when it came to applying for residency, I never thought about psychiatry. Interestingly enough, when I was in college, I volunteered at several mental health hospitals just because I was curious about kind of severe mental illness and what that would mean and how that would present. But it didn't compel me so much. And when I was 14, my dad had passed away to cancer. So I thought, I'm going to go to med school. I'm going to do oncology. I'm going to do palliative care because I don't think that he passed away well, in part because of how the medical system treats death and dying. That's a whole other topic. But when I did my rotations, what I really fell in love with psychiatry was the time. Even though it's not that much time, it's more time than you guys typically get in gynecology, right? In terms of time to spend with the patient, but also the value of hearing someone's story. That was so intertwined with the healing process and was considered treatment. Listening to how someone said what they've been through, listening to symptoms, being present with them, creating a space in that space for them to open up and share with you. And I thought that, of all the fields of medicine, this is a field where just bearing witness to someone's suffering is therapeutic. And of course, it's not true. That's in every field of medicine. It's not just in psychiatry, but I felt that power very strongly in psychiatry, in part because I think they encouraged us as physicians to do so. I don't think that they do that for other fields because of the pressure of time. So that kind of drew me into psychiatry. And then in terms of working with children and adolescents in particular, because I work with adults, but I also work with women and children, I remember meeting a child who had gone through some pretty traumatic things. And I, as the medical student, was in charge of connecting to this child on the consult service because the kid was not talking. You know, I didn't know what I was doing. I had no children. I wasn't married at that time. And I spent this whole time kind of making these little finger gestures with her and pretending to be a person because she wasn't speaking. But with that little bit of play, I could get engagement. And I felt like I really needed to be able to help unlock something in these kinds of kids. And I think that's what kind of propelled me to go into psychiatry. So that's part of it.
So glad to hear that story. And I think you're so right. Most of us who went to med school, we have this desire to help people and desire to hear people and see them. And our structures don't often allow for that to happen. And so the fact that you were this is therapeutic, this is where the good stuff is, let me pursue that. I think that's really profound. Yeah.
And sometimes, scary, right? Because I think we're trained to think we have to achieve things by a certain time. These are the things we have to check off on the boxes to be successful. And, I will tell you, my parents were not thrilled that I chose to do psychiatry. And there's a lot of stigma in this field. And you take off your white coat, you take off your stethoscope. And I miss doing blood draws. I miss some parts of medicine that I don't do in psychiatry. But I do feel over time, I've come to realize that there's such value with the work that I do. And I'm glad to be a part of the mental health care space.
Beautiful. I'm so grateful for the work that you do. You said you work with women and children. I'm curious your experience of specifically working with women and children where there are gynecological concerns or maybe even specifically infertility. You know that maybe somebody has secondary infertility. Maybe you're seeing the child and the mom is working on building the family and I should say the family, but sometimes if the mom is the access point, that's sort of what you're hearing. What do you notice from your lens as a psychiatrist in terms of people who are on the journey of fertility and also people who are trying to build their families?
I think it depends on what space of mental health you're in. So as a psychiatrist, just like as an OBGYN, you rotate through all the different fields. Mainly my work has been in outpatient psychiatry in clinic and in private practice, but I've also worked at Albany Medical Center. I was on the consultation, the CL team when I was there, as well as outpatient. So there's a lot more juxtaposition with GYN. And honestly, as a female psychiatrist on the consult service, most of the males did not want to go on the GYN floor, right? They did not want to go there. So it was mainly me and the other female physicians that would go and see these patients. And I always felt one for the OBGYNs because they were so stressed out. And because you could see on one caseload such the variety of patients that are presenting. You have women who just gave birth and then one who just gave birth for fetal demise, one who just got her uterus removed because she had so many fibroids in there. So it's just so much. So I think on the consult service, I worked a lot with women dealing kind of with that aftermath of, I just had something happen that I was not expecting. And I don't know if that's going to irrevocably change my life or not. And, I remember what's coming to mind right now is I remember working with a woman who had fibroids and she was begging her OBGYN to make sure that she could still preserve her uterus. It could not be preserved. And the OBGYN needed help telling her that it could not be preserved. Because, the OB has so many things to do, right? She doesn't have the time to sit down for an hour and process this with this woman. And kind of conversations like that where it's just such a privilege to, again, be with someone and know that they're not crazy for having all the feels and all the emotions that they have, and that they can still find a meaningful life, even if life doesn't unfold the way that they felt like it should, that the boxes weren't checked in the same way. So that's one aspect that I have. And then the
Can
other
you say that one more time? Could you say that for the people in the back?
Oh,
That you could still have a meaningful life, even if things don't unfold the same way like plan A, especially as it pertains to fertility, and that there are options that people have that maybe will unfold over time. And so I think it's really important because I would imagine that 99% of the people on this who are listening to this podcast right now, life has not unfolded in their plan A, and they are faced with all sorts of decisions and choices that they didn't even think would be in their landscape for their lives. And so just that perspective of there are people who are able to help, who are able to spend the time, who are able to unpack all that grief and shame and regret and all the things that come up when we're on this pathway, like you saw it firsthand on that service. And I think it's really, really, really important to call out that yes, the science, yes, the fertility plans, all those things, the treatment plans, and at the same time, like this emotional processing of the loss and the uncertainty and maybe navigating a different path. Those are such integral aspects of this journey that I think really deserve attention. Hello, my loves. I am so excited to share this news with you. If you are a female physician navigating the fertility journey and you want a structured, evidence-based plan, I have created a free resource for you. It's called the Physician Fertility Roadmap. I have created a guide to help you optimize your chances of pregnancy and a successful outcome over the next 6 to 12 months. Check out the link in the show notes. Love you. Bye.
And that maybe your primary provider cannot quite have those conversations with you. That maybe you need additional help or they need additional help. Like in this case, the GYN called me in for help because she knew it would be too much. It would be too difficult,
Exactly.
that
Yeah.
there needed to be another avenue in. And that's why I'm so grateful there are people like you, Erica, that can work with women who need that extra additional help. I mean, it is definitely known that it is highly underutilized, having more support during this period of infertility. The rates of depression and anxiety are very high in this population. And if you've gone through any kind of infertility treatment, that increases your risk, even whether or not you have kids, long term for depression as a
Hmm.
woman. So going through this journey alone, it does change you. And it's okay if you can find someone else to help you through it. Taking that time, having that additional person to create that space for you is going to be so beneficial for you in the future going forward.
Absolutely. I'm so glad you brought that up, the statistics. I mean, they've done studies and that people with infertility have comparable anxiety and depression rates to people with cancer. And with each unsuccessful treatment cycle, which is usually my listeners, things haven't just gone smooth sailing. They graduated from their REI. Usually there's been multiple, unsuccessful treatment layers. Maybe people are out of embryos. Like it's a really intense journey. With every single unsuccessful cycle, those anxiety and depression rates go up and up and up. And these are, my listeners are high achieving women, female physicians who are trying to serve the world. And so it's so, so, so important that we say, we deserve to be patients, both for our physical health and our mental health. We deserve to carve out the space that we need, for additional support in whatever form that looks like. And I think it's important to go to somebody who understands the fertility journey because it's such a nuanced aspect of life. But just to say, like, yes, we make time for the blood draws and the ultrasounds and all those things, but it is equally important to carve out time for the emotional side of things because for many people, this is the first thing that has really rocked the world.
Yeah.
And this does not follow that same equation as everything else that we've been taught. You mentioned your journey of like med school, residency, like same, like very type A oriented. My family had high expectations for me growing up, which I'm thankful for, right? I think that set the stage for me to do great things. And yet the equation of like work harder and you're going to get what you deserve or whatever at the end of this, that is actually not how the fertility equation goes. And so really, really, really making time and space to have a support person through this, I think is so important.
And something I want to talk about also on the other side of that, when you asked about psychiatry and GYN and this journey, is I've also had several patients who are children who are the consequence of infertility treatment, IVF children. And the narrative, of course, is I can't believe from the parents because, of course, I'm never seeing a child alone. I always see, almost always, the mother, 99.9% of the time, with that child. The story is I worked so hard to have this child and now I have so many challenges. And I remember one family where the first child was conceived by IVF, my patient, and then the second child was natural conception. And I saw both children. And the approaches of mom to each child was so different. But you cannot remove the story of how from the what's going on right now.
Right.
And so often it was such a struggle and so challenging to have this one child. Sometimes we can't detangle that from the challenges and strengths of that child. So I just want to bring that up. I don't think it's for every single parent, but I think sometimes for all of us who've gone through our own journeys in attempting to have children or having children, each journey is unique. And sometimes that does impact long term how we engage with that child, how we see their future, and how we see ourselves as parents for them too.
Absolutely. And I almost, I asked myself the question, like, why is it that depression rates are higher for people who have gone through infertility treatment, even successful treatment? Why is it that people have higher rates of postpartum depression, higher rates of postpartum anxiety? I mean, I support all the folks who conceived while in love and science. And I just warn them, I'm like, okay, brace yourself because it's coming, not to like make it a self-fulfilling prophecy, but there's something about the predisposition. There's something about the brain chemistry alterations that I think primes the system for the crash of the hormones.
Yes.
But I think it's also this expectation of like, I work so hard for this and I'm not enjoying it. And
Yeah.
this is really hard. And like, I should be grateful. Like even pregnancy, I should be enjoying my pregnancy more. And that sort of fall from grace of like, actually the postpartum time is incredibly hard. Actually being a parent is super hard. You never know what you're going to get on the other side of this. And so I think also saying like, it's okay to not enjoy every moment. It's okay to be stressed out. It's okay to be human. Just because you work so hard for this doesn't mean you can't have moments of like what was I thinking? Or, I didn't realize it was going to be this hard, we can still have those moments of like complaining and being human amidst this, because I think that separation actually makes it worse.
And I think that's where that shoulding on ourselves happen, right? Like, we should enjoy this because we're a new mom. We should feel happy being pregnant. We should be grateful that we have a team of people who are working with us to try for the third time. We should, but you are still human. And I think also there is not this shame that makes us not want to admit it to ourselves. There is this almost masochistic perseverance, right? To go through the journey of infertility, you need to be really, really persistent. You need to be stubborn, determined, gritty, and in the face of all odds, keep going. And I think we push ourselves so hard through that process that when we get to the other end, it's almost like, I can't let that drop, right? I have to keep going. But that's when we can push ourselves to burning out. And that burnout can happen not just as professionals, but as parents. And it is hard. Those first 3 months postpartum, my first son, Gavin, I didn't realize till reflecting on it afterwards, I had incredible anxiety during that first pregnancy that I had with my son. And I didn't want to admit to it. I was a chief fellow in my child psychiatry fellowship that year that I was pregnant. And I remember one of my patients came after hours and I was setting a boundary. I didn't want them to come. They came and knocked on my door, even though the front desk should not let them in. And I was like cowering in the corner, literally cowering. And I don't have panic attacks. I am an anxious person, but I don't really deal with anxiety. But I didn't realize, oh, I'm pregnant and I'm anxious. And that's why I'm reacting like a bomb is going on outside, right? So all of these things we don't anticipate just can surprise us because every single journey is different. But we're human and we're allowed and we can survive and get through it.
Yeah, so true. Before we started recording, you had shared that building your family has not always been easy and that you did suffer a miscarriage. I was wondering if you'd be willing to share for our listeners who are mostly female physicians with infertility. I think nobody talks about loss. Nobody talks about this time. Can you share a little bit about your story?
Sure. And, I don't know why that was coming up to me, but two things. When I first moved to Arizona, I lived in New York City. I moved to Arizona after my fellowship. At that time, we had a 2-year-old son. My miscarriage happened between my two boys. And he was little, maybe 3 or 4 months. And we were looking for houses because we enjoyed looking for houses in the market at that time. And I remember going to this beautiful house near some water, right? Like Arizona is a desert, there's not much water there. And the owners of the home were selling their beautiful home. It was an elderly couple. And I was just chit-chatting with the female. And I asked her, how many children do you have? And she said, I have one. And she paused and said, I have a bad womb. And I was like, what? It would just hurt me so bad to hear her say this because she believed it. And, I didn't ask her any further, but it just made me think about how could someone even feel that way? Now I'm going to fast forward. When I had my miscarriage, had the stick was positive, went in to see my OBGYN, and I didn't want to tell my husband till like everything was kind of cleared. And I remember I'm not an OBGYN, so I apologize if my medical terminology is not correct, but like the little sac and the little heartbeat.
Yeah, you got it.
And I could see that it wasn't as fast as it should be because I remember the first one. So I saw, even before I knew what it was, that like things were not looking right. So then the GYN came in and said, listen, like it's a little bit slow. It's 75. It really should be much faster. Let's just watch and see. And I remembered going home and she made an appointment for me to come back the next week. And I remember going home and like, do I tell my husband? Do I not tell my husband? I didn't say anything. And I remember going to bed every night and like holding my belly and being like, come on, beat faster, beat faster, beat faster, beat faster. Like so much energy I put into like mentally strengthening this little being inside of me and feeling so hopeful. And then also feeling like, well, what if it doesn't happen? What if it doesn't happen? And then having insomnia because I wasn't sure, like, is it going to work? Is it not going to work? And I'm going to be honest with you. I love my boys. But in my head, I'm a mom for girls. I'm a girl mom in my head. I've always wanted to have like 3 girls. That's not my life. I have 2 boys. But when I was convinced this was the girl, right? This was the girl I was going to have. So like begging, praying, like pushing mentally for this to happen and knowing I have no control. What happens. Anyway, go the next week. heartbeat is slower, but it's still going. So I went through another week of like, okay, begging and praying, heart. Okay, last week, of course, we went, no heartbeat. And then I had to get the pills to induce an abortion. And that's when I told my husband, right? That's when I told him.
Oh
And
my
he's like,
goodness,
why
you were
didn't you
alone
tell
in
me
this whole
earlier?
time. Oh my gosh.
Which I don't think is uncommon. I'm sure there are many listeners here who are like, I've done this to my husband. We've gone through this so many times. I'm just going to deal with it on my own, right? Because it's not just managing your emotions. When you tell someone else you got to manage their emotions, right? I don't have energy for that. I can only do me right now. And then I felt what this woman felt. I felt like going through that process and having the bleeding and like checking, is anything still there? Like my womb is bad, right? I have a bad womb. I felt that. I could understand the pain that she was experiencing a little bit. And it took me several months to feel like we could try again or like I would be okay with it. I remember the feeling after it was all over of reeling, emotionally reeling and like sitting in my bed and being like, oh my God, did this happen? Oh my God, did I want this so bad? Oh my God, did I lose all potential possibility of my future? Like I remember feeling all of this emotional upheaval that I had never had before, right? I never had that kind of emotional whirlwind. And part of it, I do believe, was my own thoughts about things, my own expectation management, my own, like, this was my baby girl I was going to have, right? All these, the narrative I created for myself that had no truth, that I believed was really true. And the hormonal shifts, like, I can't describe it any other way, that there really were changes in my body that had not happened before, that now are being forced to happen, that pushed me in a different emotional space. And I just want to put my hand on my heart and like send positive energy to all of the women on this podcast who are going through their own emotional turmoil, because it is real and no one really gets it, right? Even those of us who have been through something like it, this is uniquely yours, and honor that space for yourself and that time and give yourself whatever time you need. No one can create a timeline for what you need. Only you know. And it's okay.
Yeah, that makes so much sense. And I'm curious, in retrospect, do you wish you had, obviously you can't go back in time, but do you wish you had told your husband earlier, or would you have done it the same way again?
Oh, that's a good question. I don't think I would have told him. My husband's very private. Like, I don't think he would have told anybody else, but there's a saying in our culture, right? You come into this world alone, you leave alone. And I feel like there are times where our partners are with us, but I feel like this journey of pregnancy is really, we want the support and the support is helpful, and it's still a very personal journey.
Mm-hmm.
You know, it is still my body, right? Like it is still my womb. It's still my uterus. So I don't know if I would have told him. I don't think, honestly, I don't think I wanted the mental load of managing his emotions and like being
Yeah.
concerned about how does he feel about this. I guess I think I was allowed to be selfish.
Yep.
And it's not selfish, it's self-care, right? I knowing what my
Yeah.
boundaries are of what I can manage.
Exactly.
So,
And you and you know your body, and every partnership is different. And so,
yes.
yeah, I'm so glad you shared that story. And I think you're right. My first pregnancy was a miscarriage when I was a resident. And I remember like just being so excited to be pregnant. And after after I'd been told I was going to be infertile, right? Like, so that was like the whole thing was like, oh gosh, like the whirlwind. And then, then the bleeding, and oh, was it because I operated for 16 hours yesterday? And then like, okay, now I was just in this room seeing patients, and now I'm the patient myself and getting the scan, and nothing's in there, and the betas, and like, and I even told people at that point. So we were adjusting call schedules, and like it just there's so many layers of it, especially as a female physician, and just the sadness and the grief and so many aspects, right? So I changed my counseling for sure after that, because, I used to run the beta list of all the patients who had a positive beta in the ER. And I used to say like, oh, good news, you don't have an ectopic pregnancy. It's just a miscarriage. And I was like, I am never saying that expression ever again. Right. And then I really became, I think, a lot more empathetic. But I think the combination of the hormones, the combination of wanting something so badly, the loss that happens, the time afterwards where like the world is upside down, but you still want to keep moving forward. Like all of those things are so deeply human. And then you add in being a doctor, and then you have that like analytical, like medical brain overlay on top of everything else. And so I think it's deeply profound what you shared. Yeah.
And I think, like so many women, we go through this process of attempting to be a mom. Maybe we're a mom, we are a mom, or even if we decide not to be a mom, that entire journey, really does have a lasting impact on us. And we don't talk about it enough. We don't share it enough. Those points of pain can become points of strength and resilience and perseverance. But I think there, again, that space is not yet created for us to step into and share. So I appreciate you for letting me share about that.
No, thank you so much. And how many years ago was that for you? Many, right? I would
Oh,
say
wow.
8,
Gavin's
9,
10,
10.
9 or 8 years ago. Yeah.
And same, I mean, for me, that was like, I want to say, I can't do the math, but like 15, 16 years
Right.
ago now. And I still think about it, and it's just like, there's so much grief, but I do think we need to share our stories. And I think we need to also share so that other people, like both for our own healing, but then also so other people don't feel so alone.
And also there's this magical thinking, I think, on the part of that. I mean, unless you've gone through this journey of infertility, it might seem like it's everyone just has kids, right? Everyone else has no problem. They can just have sex and have a kid. But so many women have miscarriages. So many women have challenges having children. So we never know when we see a woman with however many little ducklings behind her, what she had to go through to have those ducklings, right?
That's exactly it. And, looking at it, 1 in 6 couples has infertility, 1 in 4 female physicians, 1 in 3 female surgeons. Like, these are really important stats to talk about. So if you're listening to this podcast, you are not alone. There are resources, and we see you.
I hope it's okay for me to share this too. I feel like sometimes our subconscious speaks to us. So at some point, before I was a physician, I had this dream. And in this dream, it was my mom. My mom was talking to 7 children. Now, there are 3 kids in my family, me, my sister, my brother. And those 7 kids, I was like, where is this coming from? So I talked to my mom. My mom had never told me she had 4 miscarriages.
Oh, wow.
And she didn't tell me. And I was like, Mom, why didn't you tell me? And she's like, why would I tell you? Why would I have you know about this kind of pain? And it doesn't matter because I have you guys. And I'm like, but it does matter, right?
Right.
Like all of these processes you've went through. And it was just, I think so many, especially as strong, smart women, we are so compassionate and caring about other people and their feelings and know the stories we tell can impact others. Sometimes we choose to keep certain stories close to the heart, but maybe that story can have an unfolding in power for others if we tell it. We don't have to keep everything in. And it's your time and as to when you choose to share it, but we never know what people have gone through.
Yep. And then we can have even more empathy for our own mothers too, right? We can
Yes.
understand them more. And then the doctor brain part of me is like, and the family history.
Yes,
And
yes,
the
of
family
course.
history.
Right. Right.
Oh my goodness. I did want to ask you about your perspective as a psychiatrist on, how can my people who are largely female physicians taking care of the world, interacting with patients, how can they get through their day? And that sounds like maybe a simple question, but just to paint the picture, people might have anywhere between 20 to 40 or 50 patients that they're seeing. A lot of times, maybe they're pediatricians or maybe they're in some sort of adjacent field. Maybe, people tend to ask these personal questions like, oh, like you harmlessly did, right? To your house person, like, how many kids do you have? Or do you have kids? And that is one of the most painful things. And so here you are just trying to do your job as a doctor and like you're getting bombarded with these personal questions. We do a lot of like question management stuff at Love and Science. I'm curious, like, what would you say to people who are just getting these personal questions asked left and right about either whether they're going to, whether they do have kids, how to address that to kind of preserve the energy? If you're listening right now and finding yourself nodding along, this is usually the moment people realize that they want support that's specific to them. In addition to this podcast, I offer one-on-one fertility consults where we look at your full picture with both strategy and compassion. You can learn more in the show notes. Now, let's get back to the conversation.
So that's a fantastic question. And I think every person has a different kind of trigger point with that question. I remember for me, when I worked in outpatient clinic and I saw back-to-back patients, which means you have to be super cautious about reserving your energy so you can get all the way to 5 o'clock, right? Because you know that 5 o'clock is going to be late and you got to get to them and still have enough energy for them. For me, one of those questions was, I remember I was on a virtual call and I had a mixture of in-person and virtual patients at that time. And a wonderful grandmother of a very, very severely nonverbal autistic child that I was caring for said to me, Dr. Naidoo, you must love what you do because you're so good at your job. And when she said that, at that point, I was basically burnt out. I was looking for another job. I was not having it. And I felt like, God, I have just been faking it till I make it. And this woman just called me out. I'm not ready to say this. So I had to take a deep breath and say, yes, some days I love my job. And I think that same job I had, I really was struggling with the volume and then these kinds of questions, because as a child psychiatrist, you're always asked these very deep questions. And I think, as you mentioned, there can be these niceties like, how many kids do you have? And assumptions that can just be so triggering for us.
Mm-hmm.
I think remembering that we can be pre-prepared. So one thing I would always do at the start of my day is when I had clinic, I would open up my notes for every single patient. I would read my assessment and plan and just briefly glance at it. So in the back of my head, I'm like, okay, I know what I need to do. I know what I need to do. That's a pre-preparation for my entire day. So that's why I would come in at like 6:00. My patient load started at 7:30, but I was pre-prepared, right? And so many female physicians here, you feel me, you do the same thing.
Yeah. Don't lose the sheet.
But we need to pre-prepare for this as well, right? If we
Right.
know that these questions can be triggering, what is going to be the answer that can be as authentic and as much honest as we want to be? We don't have to be completely honest, but we can choose to be somewhat honest. Or so many women are asked, how are you doing today? I'm fine. When you're really not fine, right? But we get used to saying I'm fine and knowing that it's not fine, but being okay with that because that gets us through our day. I think sometimes we have to have a canned response. And then also we have to have a time to process that. So just like that fantastic grandma who asked me this question, I have been processing that for a while, right? Maybe for you, processing it is on the way home. Maybe you take a walk during your lunch break. Maybe you step in Erica's podcast and listen to an episode that she has that makes you feel not so alone. Think about those coping strategies and when you can fit it in. And it's okay if we're late for a patient. If you need to pause between this patient and the next one, and you just need to go to the bathroom and stay in the stall a little bit longer, that's okay. That patient will still be waiting for you, right? We are used to waiting. So it's okay to not have to hit all the targets all at once because something triggers you. Because if you don't take that time for yourself, it's going to come out somehow. If it doesn't come out with your 5:15 patient who's supposed to be at 4:30 and you lashing out at them somehow, some way, it's going to come out with your spouse or with your dog or with your other children or whatever it is. It will come out in some way. So making sure you have a space to vent that out, being okay with having a pre-planned, canned response, and thinking about the strategies for you that do really help you feel more grounded.
Yeah, I think that makes so much sense. We talk about responses all the time at Love and Science for various situations. And like sometimes people deflect to like, no, but I have a really cute dog. Do you want to see a picture? Like, that's sort of a nice way to think about it. Or, oh, thanks so much for asking, but let's focus on this time is for you, like redirecting for the person in front of us in their situation. And I think that whatever we say, there's various ways to do this, but it needs to feel authentic. It needs to feel aligned. Not that we have to overshare, right? Maybe we might do that in a certain context, but like, I think that if we are saying things that are not authentic, it's going to be exhausting and it's going to add to our moral injury. It's going to make it harder to get through the day. So like having something ready to go that feels true, but like brief and that's something that we can move on from. And then, like you said, if there is something that's particularly triggering, making sure that even in real time, we can go to the bathroom stall, take a couple deep breaths, maybe splash water on the face, just like say, okay, that was really uncomfortable. Maybe text a friend who's like on a similar path, but just some way to acknowledge in that moment, okay, that was really uncomfortable. I'm going to keep moving forward. But like having a plan, like you said, I think is so important because people are going to ask those questions and it can be really hard to get through the day.
And we can be authentic without being our full self, right? We know the physician-patient role is a very unique role, and we want to preserve that alliance and that relationship as much as possible. So we don't have to share our whole entire selves, but saying something that feels real and true to us in that moment, I agree, can help us not have extra things to process later on.
Yeah, absolutely. So that's really helpful and very practical. I also wanted to ask another practical question about this notion of like compassion fatigue and thinking about if we are working a full-time clinical job, which as we know is like more than that, like it's at least 1.5 times what other people work. If we're doing that and we're balancing part-time job, which is the fertility journey of every other day blood work and ultrasounds and maybe traveling to the clinic and all those things, and then we're trying to like bring our all to our patients. I've had so many people on this journey just say like, I feel like I'm a bad doctor. I feel like I'm not 100% myself. I feel like I used to be so much better. Or maybe I'm making small mistakes. Like, how can I keep this up? I can't be all the things to all the people. what do you recommend for people who are listening or like, oh yeah, that makes sense. Like we are one person, right? And we're balancing all these rules. But I think people start to feel like they're doing certain things badly, especially being a doctor badly. And maybe they're not objectively, but that is the self-perception. And I wanted to maybe generate some ideas about that.
Yeah, and I think that when we feel bad about some other area of our life, that can always kind of be projected onto other parts of our life, right? We feel like things are not working out in this arena of us trying to become a mom. We're not doing such a great job as being a doctor, being a partner, being a friend. We can see that show up for us in different ways to reconfirm how we feel on the inside, even if it's not true, right? Again, how our brain can impact
Right.
how we really feel about ourselves. And that's where, kind of going back to principles from coaching as well as from cognitive behavioral therapy, and my mission at Do Better MD is to feel better, we have to know better. We have to know better, do better, and feel better. It is in that process and sequence. So there's a knowing, but then there's an action that has to happen before we can actually shift our feeling. In the coaching perspective, that action is shifting our thoughts. In the action, in the line of CBT or in other forms of psychotherapy, it is any kind of action that can help us to move how those thoughts and sense of identity can be. I always say to my fellows and residents that I take care of and that I help train as child psychiatrists, and I've said to myself many times as I've really burnt out in several different jobs, I'm just gonna be honest, that I cannot be all things to all people. That's number one. I cannot be all things to all of my patients, to my medical staff, to my friends and family. I just can't. Nor my colleagues either. I'm sorry to say that. But then even within the patient load, I give 80% of myself to 80% of patients.
Mhm.
I give 100% of myself to 10%. And then I give 150% to 10%. And I'm
Mm.
sure that number is not quite accurate, but the bottom line is the majority of my patients I cannot give 100% to. It is less than that. I'm still a damn good doctor, right? I can give 75% and be a damn good doctor, but I'm going to reserve that extra energy to a small percentage. And I'm going to be very mindful about where that is. And I think for anyone going through an infertility journey, especially being an OBGYN, if that is the case, or if you're a physician of any guild and you're dealing with children, so you know you're in a population where you could be triggered, to just be mindful that you're not giving that 125% to the population that is just like you,
Mhm.
because then it's going to become a little bit tricky. That's where we think about in psychiatry the term countertransference. What do we
Mhm.
feel about our clients, our patient, that makes us react in a certain way? Being mindful of that and knowing that we may or may not be able to give the things to our patients that we cannot get for ourselves. So we can try to give it, but we might be setting ourselves up for a reaffirmed failure again if
Mhm.
we know that they are lacking in a space that we are lacking. So I'm just bringing that up. But it's okay if we decide that certain patients don't need 125%. And for any patients potentially listening, that doesn't
Right.
mean that we're not taking care of you. That just means that the amount of critical thinking, the amount of emotional energy, the amount of all the extra things that doctors put into the art, we can
Right.
still be artful and still be competent, but just not give all of those things that will drain us, because it's that extra 10% that we were doing 150, that is what's going to drain us.
Yep, that makes total sense. And what I'm hearing you say is like, first of all, what we define as our 100%, maybe somebody else's, am I doing the math right? Like just a different number, right?
Yes,
Like, so
right.
like we have incredibly high standards for ourselves. And
Yes.
so again, we shouldn't necessarily compare, but just saying that like what we define as 100%, maybe the industry might actually even set a lower bar because we are just such high achieving people that we feel like we need to be doing this all the time. And so just noticing where we may be over delivering already, which
Yes.
is burning us out.
Yep.
Another way that this could look is perhaps, if we have, say, in my world, I have 30 minutes. I'm so excited to have 30 minutes to see a patient, but sometimes it doesn't feel like enough in my doctor world. And maybe it's like we spend 20 minutes with the patient. So we have time to,
Right.
write the note, communicate with the team, do the other things so that we're not doing that at 7 p.m. And then the next day, we don't have gas in the tank to give. Maybe I've
Yes.
heard some clients who are maybe surgeons and they say, you know what, I'm not going to do any of like these sorts of cases during this particular time because of XYZ. And so it's not all or none, but it's like turning up or down the dial and saying, okay, I have less reserve right now. I have to be strategic with my time, not just my time, but my energy so that I can weather this phase in the best way. I always tell people, spoiler alert, fertility takes energy. And if
Yep.
we are maxing out in all the domains and then fertility is an afterthought, it's probably not going to work as well because we need to make a room in the house for that as well. So I think those are all really, really amazing strategies. And to give ourselves the permission, I mean, my notes are admittedly B minus notes. And my administration hasn't come to find me yet because I checked the boxes, but I'm done with over delivering on the notes. And if I need to communicate with somebody directly, I will do that. But I have to make it sustainable for myself in whatever phase of life I'm at. And looking at the time and energy audit of the clinical medicine and saying, okay, what's acceptable? What's good care? What can I delegate? What can I let go of? Those are the kinds of questions I think we need to be asking, especially in a season of life that takes more.
And what's coming to mind right now is that I'm actually currently working on a meditation practice to build more energy because I've been dealing with a lot of fatigue. And in this particular meditation, there's a visualization of this big golden sun above your head that is full of your own energy. You fill it up with your vitality, your joy, your perseverance, your positivity, your dreams, your aspirations, and then you pull it into your body. And why I'm bringing this up is because in this visualization, you have to fill this tank, that you have to create this sun. And I think sometimes we think that we just have to rest to get energy. But no, we have to engage in doing something to bring that energy back to us. And that's where that strategic part comes in.
Yeah, that's right. And along with that, I mean, we talked a little bit about this earlier in the conversation, but I love for you to re-emphasize, just as we actively visualize and draw that into ourselves, how can we, as people who are givers, who live our lives around other people's schedules and needs and everything, how can we give ourselves the permission and carve out the time to seek the mental health support that we need? How do you help your clients and your patients do that in a way where they feel like they can take that time? Because that's one of the biggest barriers I think that people have is like, well, I can't do that because other people need me so much in XYZ ways.
So it's interesting because I think as givers, so many women are givers, and I love working with women of all age ranges, but especially professional women just like you. Sometimes their care for themselves is only put into perspective when they think about how it impacts others.
Yeah.
If they realize that their own difficulty with managing their own time and their energy causes a trickle-down effect on impacting their patients, people who they care for and love, the space around them, sometimes that will remind them, okay, I need to take care of me so I can take care of XYZ person. That's not my favorite, but that is often the most frequent thing because they can feel the impact of how them not doing their best or them not doing whatever they consider enough is going to impact the lives of others, and that can motivate them. Kind of like that obliger kind of theme in terms of what motivates people to do things. I also think another option to consider this, which I think is very common in the coaching world, is future self, right? What is your future self? What does future self want to achieve? What does she want to be like? What does she want to do? And what can I do right now to help set her up for success? Because I owe it to future self to do the things I need to do for myself. Then finally, if we can be real, not with our thoughts, but with our body. I think sometimes the body keeps score more than the mind because the mind can play mind games with us and make us believe things that may not be true. But your eyes are dry. Your back is paining you, right? The soles of your feet are aching and you want a massage. Go get the massage, right? Like listen to your body. If it's telling you it needs more sleep, it needs more nourishment, it needs more water, it needs to relax a bit, it needs some magnesium, it needs an Epsom salt bath. Sometimes if our body is speaking to us, let's hear it.
Yep.
That's what I was saying.
Beautiful. That's a mic drop moment, my friend. That's amazing. Okay. I love your practice. I am obsessed with what you're doing. I am so grateful that you're in the world. Can you tell us a little bit about where people can find you?
Absolutely. So if you are interested in becoming a patient or client of mine, I really love working with prickly pears. What I call difficult teenagers are my thing. I also love high achieving females. I also really enjoy working just as you do with the healers. So those who are in the mental health care space who are really trying to manage and prevent burnout and compassion fatigue. Those are the women that I really love working with. So you can always email me at knowbetter@dobettermd.com. You can follow me on Instagram at Dr. Shivana Naidoo, and my website is dobettermd.com as well. And if you want to listen to my podcast, it's called Thinking It Through with Dr. Naidoo, Child Psychiatrist.
Beautiful. Thank you, Dr. Shivana. It's been such a joy to have this conversation, and I know it's going to help so many people.
Thank you so much. Have fun. Be well.
Absolutely. And to my loves, you know how much I love you. Until the next time. Bye.
Bye.